us together, for all of you for attending. We have about a half hour for an open discussion. At around 4:15, we'll have the Attorney General join us, and he will give some remarks, but I'm told he also wants to listen to the group. And so we will have a half-hour discussion to share some of your thoughts. There should be microphones around, so if you want to raise your hand and make any comments. But we're really looking for our conversation around solutions. I think for the first hour or so, we've heard a lot about the challenges. And what we're looking for are more specifics on how are folks dealing with this. I will just open up from a National Association of Counties perspectives. Obviously, the sheriffs are part of counties and are instrumental. They're going to tip the spear on this epidemic. But we're looking at this as a really multi-generational impact. It's a full community impact. And whether it's the Child Protective Services, public health, public safety, workforce development, it really is impacting counties, governments as institutions, but also counties as geographies, as communities. So with that, why don't we open it up and see if anybody wants to kick us off. This group is not that shy. I looked at the list.
Just raise your hand.
So Mr. Leon Evans, who has a new consulting firm, 3 Bear Consulting. The first 2 bears were literally live bears that he wrestled.
And the third was Bear County, where I just retired as the behavioral health authority. But we have a great community collaboration. We talked a lot about it today. But we have great outcomes. The homeless count downtown San Antonio is down to 85%. We never built an additional 1,000 beds onto the county jail limits plan. Number of people in emergency rooms inappropriately with behavioral health and addiction problems is down to 50%. But a lot of that is because of community collaboration, but most of it is because of non-traditional kinds of treatment and motivational engagement, using peers, using a sobering unit rather than taking people to jail and charging them with these minor crimes, doing motivational engagement to get people into detox. Detox is important, but what's really important is how long you maintain your sobriety after your detox. So there's a homeless campus called Aim for Hope. The main part of it's alcohol and drug-free campus. You inside a transformational place that should be alcohol and drug-free and work 8 hours a day. We operate 2 dorms that are called in-house recovery. They're evidence-based treatment when you seek safety, but you can stay 120 days. And just because you're detoxed doesn't mean your brain chemistry is working right and you got your life back. But in 120 days, you start figuring out, you become listening enough, you start reading what you've done to your family, your children, your friends, and yourself. You learn about your disease, how to manage your disease. So it's very inexpensive. It's like a bunkhouse. Everybody that's the staff there, they're all in recovery. So that's really the secret is the sober living part of it and reduction in relapse. So I just want to make that point that a lot of stuff that really works isn't that expensive. It's non-traditional medicine.
Thank you. And since, Jonathan.
Yes, my name is Judge Mary Celeste. I'm a retired judge. I'm here on behalf of the American Judges Association. We are an umbrella organization affiliated with the National Center for State Courts, along with 6 other entities, or 5 other entities. We, at the American Judges Association, hold mid-year and annual conferences. And at those conferences, we educate judges about current issues. Of course, opioid epidemic is a big issue in the courts, and we will be focusing on that. We have a joint conference coming up with the Illinois judges and our American Judges Association, and we are focusing on the opioid epidemic. There are other organizations that are affiliated with the courts, the National Judicial College, where I'm an adjunct faculty. We teach judges about all current issues. The National Association for Women Judges, and another organization that's actually housed here in D.C., the National Association of Drug Court Professionals. Currently, there are 3,100 drug and treatment courts around the country, and they're in the family setting. They deal with impaired driving, They deal with felony possession charges and so on and so forth. But as a co-founder of our DUI drug court in Denver, I can tell you firsthand, being in the trenches, that we see people with addiction issues many times. And currently we use MAT, the medically assisted treatment. And as part of using MAT, medically assisted treatment, recently the FDA approved implants for Suboxone, but it's very expensive. To give you an example, Massachusetts right now, the state's largest insurer, has agreed to pay for this implant. It costs about $5,000 and $825 a month. And some of the other insurance companies are hesitant because of the cost. So they're not doing anything. They're still paying for the cost of the buprenorphine and which is another name for Suboxone, methadone programs, which is far less expensive. But it would be good if we had some resources, money, that would assist these people with this, which has been found evidence-based best practice. There's more and more research on the implants. They put them in for 6 months. They test them in these REMs, which is a supervised oversight of the MAT treatment for using this particular methodology. And I don't know if these funds that have become available through the administration now are available to pay for some of these REM programs, so these people can get on something that has been proven to be effective for the opioid use disorder. But it would be good to know where we can go, where the courts can go, where the National Association of Drug Court Professionals and all the affiliated judges and court personnel, probation officers, parole officers, treatment providers, they're all there at NADCP. And there's many NADCPs in over 20 states across the country, treatment court associations. But where do we go to find funding for the people who come before the court who want to try this new approach for opioid use disorder?
Great, thank you, Judge. I'd like to comment on that, where one of the challenges we face, the sheriffs as well as the county overall, is when you are arrested and you are on Medicaid or veterans benefits, you actually lose eligibility for those federal benefits. So not a conviction, you haven't been adjudicated, you're in a pretrial status, you are either terminated for Medicaid or VA coverage or you're suspended. So when you are in the jail and you need health care costs, the county is typically picking up those costs. Plus, as the inmate, you lose treatment in some cases, and then by the time you transition back into Medicaid and VA coverage, it can easily be 30 to 90 days or longer. So we've been pushing Congress to change the Social Security Act so that you don't lose your Medicaid, Medicare, or VA benefits until you've been adjudicated. That in this country you shouldn't lose public benefits at arrest, you should have due process. That would help with continuity of care. There are several bills on Capitol Hill now in the House and Senate that would actually correct that. And it went back to one of the sheriff's earlier explanations on the difference between jails and prisons. When they wrote the legislation, the Hill staffers who wrote it didn't understand that when you're in a county jail, you're typically 80% of our inmates are probably pre-trial, depending on the county. And so they just use the term incarcerated, and that you are at the cost of the state. So that is a big deal for us. Just to give you a snapshot of the cost, for a 12-week regimen of hepatitis C prescriptions that some of the jails and prisons are having to pay for because they're typically uninsured, it's easily $43,000 to $95,000 per inmate for a 12-week. If they have HIV, it can easily be in the hundreds of thousands of dollars for treatment. I just talked to one rural county in Georgia on Monday who put aside $50,000 thinking that'd be enough, just one inmate has cost them $200,000 already this year. So when I say the county, what I mean is the property taxpayers in those communities, both businesses and individuals, are picking up that cost. Anybody else? Sir? I think there's a mic right behind you.
I just want to say that on behalf of the National Sheriff's Association, as a member, I'm very proud that this has happened, and I want to say before we leave here, we certainly shouldn't lose the opportunity to try to do this again. This type of group coming up with the solutions and working together can have a powerful influence on national policy, and we certainly need to look forward to doing that in the future. So I want to thank everybody who did come, and I want to thank our executive director for having a vision to try to put this together. And again, thank you for all being here.
Sheriff? Mr. President.
Thank you. I'd like to reaffirm what Larry just said. I think it's a very important meeting. As I've traveled around the United States to various states as president of NSA, no surprise to me, but sheriffs deal with the same problem regardless of what state they're in. Mental health issues are big for us in our jails. And just to give you a glimpse of where we are in Texas, Harris County, which is Houston, the largest jail in Texas, obviously, they have more mental health beds than the entire state of Texas has. And yet probably 40-45% of the people in our jail have some type of mental affliction. And the fact that they've done away with mental health facilities in our state and many other states, our jails have become a dumping ground for mentally ill people we have to deal with. The other thing is we cannot lose this battle against opioids and other narcotics. We just cannot. I know all of you probably heard that if the United States ever fails, it will be internally, it won't be externally. This threat is dangerous to our country and the security of our country, and the reason it's so dangerous is our borders have been porous for 40 years or longer. We have to secure our borders. The other thing that's incredibly important to law enforcement that I don't think we've done a good enough job to explain is asset forfeiture. In 15 states in this country, the states require a conviction before you seize assets. That's the benefit to the drug cartel, and that's a detriment to law enforcement. But I think we're partly to blame for that, because I don't think we've educated the public just how dangerous the cartel is and how we can hurt them by taking their assets away from them. The people that are opposed to how we do it, in most cases, they always want to take an isolated case and use it as an example, but it's not representative. 99% of the people out there in law enforcement are doing it the right way for the right reasons, and we need to make sure we get that message out there so we don't lose that asset any further than what we already have. Thank y'all.
Thank you, Sheriff.
Hi, I'm Ron Brooks. I'm the Executive Director of the National Narcotic Officers Association's Coalition. I want to thank both Executive Director Jonathan Thompson and Dr. Meyer. This is an incredible forum because, as you all know, when you bring this constituency together, it's not a law enforcement problem, it's not a prevention problem, it's not a treatment problem. It is a problem that requires all of that. It's really a three-legged stool. I wanted to say that, as Jonathan mentioned at the beginning, he talked about the blood of cocaine that's sitting offshore. I started with narcotic enforcement in '74. I worked 38 years in the field, 45 years total in the policy issue. And I've been through every kind of crisis we've had. We had an opioid crisis back in the '70s, and then we had a crack crisis, and then we had a meth crisis, and then we had, marijuana flooding across the country. It is very important for us to stay focused on this opioid crisis, as everyone has said. But we need to remember we're a polydrug country. We can't chase just those shiny objects. I was just at the ICP Narcotic Makers Drug Committee meeting in Atlanta last week, where many of the representatives said, hey, we know opioids are a problem, and we experience it in certain counties, but we lose more people to cocaine still, or we lose more people to meth still. So I want us to stay focused on that, and I want to applaud the way this was brought together, because if we don't all If we only look at our own lane, law enforcement or prevention or treatment or public health or the faith community, we will lose this. But if we come together and coalesce around this true crisis, and I agree with the sheriff that just spoke, this is the greatest national security crisis we face. It can destroy our economy, our resiliency, our workforce, and our families. So I applaud you for putting this on.
Hello, my name is Sylvia Cruz. I'm a board certified OBGYN who went into law in order to kind of address some of the issues that we're talking about here. And it's very heartening to see so many people here to address this opioid crisis. Most importantly, I'm the mother of my daughter who just was at a very quality giving hospital here in the DC, Maryland, Virginia area. And I'm very for this controlling this opioid crisis and finding a solution. But what I've seen as the mother, seeing my daughter go through pain and the people on the ground saying, well, we're trying to decrease the number of opioid prescriptions being written. She went from screaming in pain for 30 minutes and looking for it, and physicians saying we're trying to use other alternatives besides opiates. And because of her condition, those alternatives were not viable, but yet there's that need to decrease the numbers. So I want to be the voice to say there should be also a cautionary note as to going down that road to rush and say, well, we need to cut the number of prescriptions, because what happens is those people who have a legitimate need for those opiates are not getting them and are being tortured, which is the only thing I could say she was going through in that hospital room. And I was sitting there watching her scream because of that need to decrease the opiate use. The other thing is, and the judge addressed this, is that insurance companies all talk about, yes, there are alternative methods to use instead of the use of opiates. But those are empty platitudes, because when you get to the point of you want to send your patient to acupuncture, you want them to get massage therapy. Alternatives that have been shown to be effective, they're not covered by insurance companies. And insurance companies look at the federal government, Medicare, Medicaid, to see what is going to be covered. You know, what are they going to reimburse? What will they pay to allow these patients to overcome their, to not have to use opiate medications? And those things are not being covered. And the other thing I look at, I've seen as a problem is that we're going from one medication or replacing that medication with another medication, which also has the potential for abuse as with any other medication. So I just want to be that voice that hopefully you'll keep it in the back of your mind that, yes, there is an opioid crisis, but then if we go too far, the people who do need it aren't going to have it. Thank you.
Thank you.
Hello, I have a question. I guess think about what we discussed today on the EPTA being local in nature, and that the work that we're doing is data-driven. I think that what we've heard across all the speakers is we're collecting really great data from HHS, from USDA, from Department of Education. How do we create a national policy initiative that assists localities specifically in accessing data, or creating a more comprehensive way for each individual stakeholder, shareholder, to be able to access data so that we can really help youth and families around prevention and education, so we can prevent cause. And to the extent that we are collecting data on treatment services, how are we going to capture data on the sustainable recovery effort as well? Because we've heard this as being prevention, as well as sustainable efforts around recovery. So if everything should be evidence-based and everything should be data-driven, how do we make sure that we're able to access that data collectively so we can work together to create best practices?
And
Sheriff Petrusian, I think. So several in the room with HIDA, an OD map. And I'm not sure where HIDA is sitting. Shannon, I don't know if Shannon is still here. But OD map is one of the data-driven technologies, obviously, that everyone is looking at, trying to share information. Sheriff Petrusian, I'm going to turn the mic over to you for a minute, also is very big on data-driven, and there's such value to this. But I think there's a question of how do we have public health and law enforcement marry together? Is there some way that we can share the information and then work together to share that information? And who would have access to it? There's a lot of different hiccups and hurdles with that, but it's a fantastic question because this is one of the great questions that we can work together to collaborate on. So I'm going to turn over to the sheriff to address it, and then I think we'll come down to the end of the table.
Thank you, Carrie. Well, quite honestly, I don't know if you carried, you were setting me up this nicely. Thank you. But in just having Matt here, we just on Tuesday announced a major initiative through the combination of the National Association of Counties and the Lawrence John Arnold Foundation. We got a significant grant to identify super utilizers, to actually break down the silos that occur between police or patrol, corrections, health providers, first responders. And then if we can actually identify these folks, we can actually step in and proactively help them out rather than reactively. These are the people that you see cycling in and out of our places all the time, over and over again and over and over again. We never get them the services that they need. We may not even understand they're a super utilizer. So just as a proof of concept, just to give you one idea in a simple way, Cambridge did a proof of concept showing a young woman, 26 years old, within a 4-year period of time had 28 engagements with first responders and with law enforcement. So police may not even know her name because of the 14 police engagements, only one was the perpetrator, alleged, right? 13 others were the victim and a witness. And when you then, the police wouldn't necessarily know about 14 times she had been treated for an overdose by first responders. That's just on just 2 silos we broke down, right? So this initiative, done with a DACO, is really something that's going to be special to allow us to identify who they are, to get them the services that they need, to divert them and to stabilize them. And quite honestly, not just keep them out of our jails and out of our emergency rooms. The Mass Hospital Association joined into this initiative, the League of Community Health Centers has. And so everyone's in. And it's not, again, just to stop them from clogging up our jails and our police stations and our emergency rooms, but actually get them the help that they need, right? I mean, it's not just diverting them from arrest, it's diverting them to the resources they need. So I really just want to applaud NACO for stepping up along with the Lawrence John Arnold Foundation to be able to provide some of the stuff that we're speaking about, data-driven model practices, things that we can utilize, then replicate, in tailored and appropriate ways across this country that can help us all, avoid unnecessary arrests and unnecessary hospitalizations.
There's a lot of interesting work going around in the data field, obviously, in criminal justice, healthcare overall. And what the Sheriff was talking about, we started this initiative focused on mental health in jails. And Leon actually was a leader in Bexar County, Texas, San Antonio, and Miami-Dade County as well, among others. And it was really, if you look at county governments, and not even all of our other partners, we own 1,000 hospitals. We own responsible for public health, behavioral health, jails, et cetera, and homeless shelters. And the counties weren't integrating their own data sets, and then including with the city police force and then the courts. And so groups like Miami-Dade, which is a county of over 3 million, they dug into their high utilizers and found 30 individuals who were accounting for well over $5 million a year. And the same thing in San Diego County, same thing in rural counties. And yet there wasn't really a wraparound approach to the individual. It was all silos of excellence. And so they were dealing with them in their each field and not really looking at how can you deal with not just that individual but their families. Because so oftentimes there's children involved in these situations. And now we can use that same template with substance abuse and other things. There's also some interesting crowdsourcing going on where there are new apps where actually families and neighbors can start identifying where they think there are folks that need help. So it's not just on the tail end where our coroners process the body and then hopefully fill out the death certificate appropriately, because there's a real problem with that. And there's different incentives for them to label the death other reasons. So it's very complicated, but it's interesting to see the crowdsourcing and actually the communities starting to develop maps, not just the public sector. But looking back.
Hi, good afternoon. My name is Chevelle. I'm with the National Association of County and City Health Officials, and we work very specifically with serving as a voice for health departments throughout the country, with the membership of about 3,000 health departments. And we were presented with an opportunity at the end of 2017 through the Centers for Disease Control and Prevention of working with high prescribing, high overdose areas throughout the country. And we actually were able to work with 4 specific sites in Delaware County, Kentucky, Hillsborough, or Manchester, New Hampshire, Montgomery County, Ohio, or Dayton, as well as Boones County, West Virginia. And one of the things that was a very unique process about this is that we actually were able to work in collaboration with the various stakeholders in those communities, with law enforcement, as well as the health department, as well as those stakeholders dealing with therapy and treatment in those areas, to work a lot in collaboration to put together a community action plan. And so working with the local health departments to put together very specific deliverables. So although it's very unique and specific for Foresight, certainly having funding for many of those local health departments throughout the country for those type of collaborations, I think would go a long way.
Great, thank you. Sir, sorry.
Good afternoon. I'm Sheriff Gabe Morgan, and I'm glad to hear you and me talk about collaborative work. Because I'm sitting here and I'm kind of shaking my head because we're talking about reaction. Everything that we've been saying this afternoon, we're reacting. And if we're reacting, it's like going to the prom. You get there, and it's the after prom. You didn't get there for the prom. You didn't get there before the prom. So one of the things that we have to do if we're going to be successful is go further upstream. We have to talk about prevention, treatment, education. All those things are important, but unless we go further upstream, all we're doing is picking up bodies. So I just want to challenge this group to get outside of the normal way of thinking and understand that reaction and treatment and how we're going to deal in the community is only a small part of it. We're the folks that are dealing with social issues and social policies because there's a whole lot more underlying issues that we're not addressing. We can't rock our way up out of this issue. We can't treat our way out of this issue. We have to go back upstream and begin to talk. This isn't new. As the drug enforcement officer talked about, this is my second go-round with the opioid epidemic. So it's just a cycle. And we wrote off a number of communities early on when they were going through certain epidemics. It will continue to spread. It's like cancer. If you got cancer of the toes and you don't treat it, the underlying issues, it will spread to the whole body. So here we are, we're still talking about reacting. How about let's go back and figure out how do we begin to divert it, stop it? Because if we don't control the craving, the need, what drives people to it, there's not a whole lot we're going to do on the other end except count bodies.
Thank you, Sheriff. Sheriff, we call that the kindle and the spark, that this particular phenomenon is the economic and cultural issues coalesced around corporate incentives to peddle, whether it's cartels or legitimate corporations. Their businesses And if you take away the demand, their business will go away. So they're not the root cause, they're just supply. We've also, go ahead.
No. And I want to piggyback and echo that. One of the big issues that we have is we are really looking at the shiny object. We're chasing that piece of it, and we're glorifying it. To a point, we're getting the message out about opioids. That message is there, but I'm telling you now, based on conversations with other people in recovery, we do not start with heroin and opioids. We start with things way before that. And I can tell you, having conversations with my kids, their mindset, because I'm very open and candid about my addiction and my recovery, they understand the opioid piece. But there are other things slipping under our radar that drive us to this point. I didn't wake up one day and say, hey, that my career is going to become an addict. It's fantastic, I can't wait. No, it started way before that. The mental health, the other drugs, all of that. And if we don't really combat that piece of it, we're going to continue, and what we're going to do is we're going to be blindsided by other drugs that are out there.
We tend to think about that in three buckets. The legitimate injuries, someone who has a root canal or a car accident and gets onto legitimate pain medication. The recreational users who follow that progression. And then the self-medication, those who probably have mental health or some trauma or something else. So it's those legitimate injuries, the recreational use, and self-medication. And they require different strategies and tactics to deal with in the community. Sheriff? Sheriff?
I'd just like to piggyback on the last two questions or comments that you had there. It does concern me. I go out to as many DARE graduations as I can, and you just mentioned recreational drug use. Now, I just think that term is pathetic. I mean, when I think about recreation, I think about maybe being in a canoe or walking my dog or throwing a frisbee. I don't think about sitting around with my friends smoking out of a bong. It just doesn't make any sense. But I think what's happening, we have this sort of acceptance that's going on throughout the community. Even if you read the President's Commission on Combating Addiction and the Opioid Crisis, you'll find that people that start with marijuana are 2.5 times more likely to end up doing opioids. And I sat on several panels where people that had recovered had actually, it wasn't because they had started opioids because of an injury or a prescription, as they started with marijuana. I know I'm in the minority nationally when it comes to that, but I think that's an issue that we've got to at least address with the importance of getting away from this mindset about recreational drug use. And I think there's a lot of ways to get that message out. I think one of the, certainly ODCP, and I believe they're going to go on a very proactive campaign on this. But I also think there's a lot that we can do with our own community resources. Get out to the schools, get out to teacher conferences, get out to, we briefed all the principals within our county to make sure that they're on board, and even on the Jason Dragon movie and all kinds of stuff to try to get the message out there. But there's a lot of resources that we already have within our own communities that we can utilize. It doesn't take a lot of money, it just takes a lot of effort, and a lot of energy, and a lot of getting together and trying to get a plan together. Certainly money helps, but there's a lot that we can do already, and I agree with Gabe. I think what we got to do is, when I look at treatment, that's when prevention and enforcement and education and all that haven't worked, and now you're into the treatment mode. So we've got to do as much as we can to be proactively on the front side to try to address this problem.
Yeah. Yes, sir.
So, how you pay and what you count drives behavior. And in healthcare, forever, we pay for what I call car services. We pay for inpatient and outpatient services. But this very small group of people that we're talking about today, they need motivational engagement, they need case management, we're talking about how you utilize your social wraparound services, they need crisis respite and things like that. If you have severe mental illness in the United States, you die 25 years sooner than the general population. In Texas, it's 29.4 years sooner. But you're not dying of your mental illness or addiction. You know, way over half the cigarettes are smoked by people with behavioral health. We know what that does to your heart and lungs. You start self-medicating with alcohol and drugs because you go undiagnosed, that early intervention or prevention, and you're so disabled because of your physical and mental condition, you're not going to work. So you have no health insurance. You're never going to get primary care, early intervention, prevention, or disease management. So Malcolm Gladwell wrote an article for the New Yorker called $1 Million Murray, where he tracks his Afghan vet who comes back, has post-traumatic stress, he starts acting out, self-medicating. He gets dishonorable discharge and loses his health care. He spirals quickly into homelessness because of his drug abuse and behavior. And Malcolm Gladwell just went and added up all the costs to the hospitals and emergency rooms to over $1 million. So his premise is one of the things that's really driving up the cost of health care is this very small group of people. Well, like the sheriff was saying earlier, same thing's true. You were talking about data collection. These high utilizers, the homeless, chronically persistently homeless are people with mental illness and addiction. Google the cost of taxpayers that are homeless, and you'll see it. The cheapest study I saw was like $40,000 up to $120,000 a person. I mean, just somebody to argue with validated that amount of money we're wasting. So we need to rethink about how we wrap services around people and how we don't have perverse incentives in payment to get these people treatment.
We're going to go back here and then over here.
Thank you. Byron Odico, the Executive Director for the Wyoming Sheriffs and Chiefs. Let me take a moment with you and capture a specific point not yet shared by some of my fellow colleagues, and that is early age intervention, education, and prevention. At 2 in the morning, if you ask any of my officers who's in trouble, who needs it, who ought to get it, they can give you a pretty fair list. Problem is, I don't have anybody to give a list to. In most communities, that service doesn't exist. So then what happens? Oh, a couple weeks later, at 3 in the morning, I arrest them. Got them in jail. We know they need treatment. We know they have something that we've now intervened, and they need some follow-up. Got them on the list. Don't have anybody to give the list to. So out the door after they see the gentleman in the black robe who puts conditions on them they can't meet, and they come back. And pretty soon we're cycling through, and if only we could have had some early intervention, treatment, and follow-through. I'm in the only business where no business is good business. So I'd just soon not have them to deal with. My community would be a lot safer if we had those resources to be able to deal with them. I've been a proponent for a long time of trying to figure out how to engage public health, if you will. In part of this discussion, we did an attempt at times to do the school. We've done it from time to time. We have some folks who start up some program in some communities you'd love to replicate. But on a grander scale, across the board, who and where can I hand that list off at 3 in the morning of those that need the early intervention, treatment, and follow-up?
We're going to go back behind you and then to the table. Then we've got time for 2 more. You a quick one?
Yes, sir. Keith Everhart, Hardin County, Ohio Sheriff, a very small rural county. One of the issues in rural counties is we can't get the services. Just to give you an example of the issue, and I realize this is a state law in Ohio, but it's a prime example. When you are convicted of any type of drug offense, the judge is mandated to take your driver's license. But they're also mandated to put you in treatment. Well, we don't have enough treatment in our county, so now you're either forcing people to not go seek their treatment or break the law by driving. And we don't get the services like the larger metropolitan areas, but yet we have the same issues. And I don't know what the answer to that is, but it is a real problem in rural America.